Pain at the back of your heel. Ouch. I'm Dr. Paul Zalzal.
I'm Dr. Brad Weening.
Dr. Danny Arora, thanks for having me, guys.
Thanks for joining us. Welcome to Talking with Docs, where we talk with docs. Today we're talking with Dr. Danny Arora, a foot and ankle specialist, about what's the deal with the pain at the back of my heel.
Right.
Let's go. A lot of times people come and say they got a lot of pain. It can be very debilitating, actually. Difficulty going up and down stairs, difficulty walking. They have to wear open back shoes, or they come in with their shoe, but their heel is kind of tucked underneath the foot, or they're wearing some type of sandals or stuff like that. A lot of times they have this large bump that's growing, or they think on the back of the heel. Essentially what that is, or can be, is insertional Achilles calcific tendinitis, or calcifications where the Achilles tendon attaches to the back of the heel on the calcaneus, which is the heel bone.
Okay, don't confuse this with plantar fasciitis, where the pain is at the bottom of the foot in the front of the heel. This is at the back, right where the Achilles tendon, which is a super strong tendon at the back of your ankle that lets you stand up on your toes. That inserts into the calcaneus, or the heel bone, and that's where the problem is with this condition that we're talking about.
So let's talk about who gets it and why are they getting it.
Yeah, so I think a lot of times, again, middle-aged people would tend to get it. Sometimes people who are trying to be active, repetitive type of work, they could get a lot of irritation in the back of the heel. Essentially what happens is there's too much inflammation in that area. You could develop some calcifications, and then there's a bump that ends up growing.
When you say irritation, do you mean irritation of the tendon pulling on the bone, or irritation of the shoe on the back of their heel?
Well, there's the external irritation with footwear and rubbing and friction, and there's also the irritation where the tendon is irritated by the calcification or the spur that forms in the back of the heel.
And this used to be called a pump bump. I've heard that term thrown around.
Yeah, you could see that. It's like the people walk and they have this huge kind of golf ball in the back of the heel.
Okay, I guess that comes from wearing the pumps, those high heel shoes, that thought to be the etiology.
The theory of that, yeah.
Okay. All right, so someone comes to your office, what are you gonna do on history and physical examination?
Yeah, so I think, again, like anything, find out what's causing their pain, where their pain is. That's the biggest thing. Is it really on the back of the heel? Is it on the bottom of the heel? Right. Make sure we get the right diagnosis. After that, a lot of times to assess the severity of their symptoms, what they've done already in terms of treatment. And I would say the first line of treatment is usually a non-surgical treatment, or more of a conservative approach.
Okay, and are you getting imaging for this at all, X-ray?
Yeah, so 100%. So a lot of times people come with an ultrasound, but for me, the biggest thing, yes, ultrasound could be helpful to look at the tendon quality, inflammation, whatnot, but the key is really getting an X-ray of the foot, or a view to see the calcification, the bony architecture, and to see what's going on at the bony level there.
And this would be a weight-bearing X-ray, not only from the top, from the side, and from the back.
Correct, and the key is really that side view, that lateral X-ray, to see what's going on there.
Okay, so there we've seen what you're going to do on history, on physical examination, investigations. Now we've made the diagnosis and we jump into treatment.
First line of treatment is usually non-surgical. A lot of times people like using an anti-inflammatory cream to try to decrease the inflammation locally. Sometimes people like to get a half-size shoe bigger to get less of that, rubbing effect. Little heel bump to lift the heel to decrease the tension of the Achilles tendon.
Make you taller.
Yeah, that could maybe give you a couple inches potentially.
There you go.
And proper footwear again, activity modification. If something's really worsening your symptoms, you might want to kind of ease off to decrease that irritation.
All right.
What about physiotherapy?
Yeah, so physio could help. We want to stretch the Achilles tendon. You want to decrease some of the inflammation. Sometimes adjunctive modalities like ultrasound therapy, ways to minimize the inflammation of the back of the heel. That could help. Some people come and ask about Shockwave therapy.
Okay. What is Shockwave therapy?
Yeah, so essentially it's a kind of an ultrasound-based therapy where they really just kind of pump the area to decrease the inflammation and stimulate some type of soft tissue reaction.
Okay.
All right.
So does that work? Good question that I just asked. I have a lot of patients who've told me they've done it and helped. Okay. So then I started looking into that. The evidence is a little loose, so I don't necessarily recommend it. However, sometimes I do say you could try it if you could kind of mix that with your physiotherapy treatment. If it helps, then why not?
Okay, so those are a lot of different non-operative, conservative ways you can try and treat this. And you're getting 3 surgeons here telling you, try the non-operative stuff first before you jump into surgery. Always, always, always try non-operative treatments before you consider a surgical intervention. Having said that, let's say you've tried all this stuff, it doesn't work, you're debilitated, are there surgical options?
Yeah, so once we go through that non-operative kind of path. If patients are still quite symptomatic, a lot of times they say, I've tried all that stuff, nothing's working, doc, you got to get the pain out, because it could be very debilitating.
Right.
And I would say the surgery really alleviates the pain, and the patients are extremely happy from it. So the surgery could be a couple things. So number one, if we're just talking about that Haglund's deformity, a lot of times we could take that down arthroscopically. So we go with a couple of poke holes, minimally invasive, with a scope, and we shave down the bump of the in front of the Achilles tendon.
And that's different from the way they used to do it, right? They used to do a big open incision because we just didn't have that technology.
So that's just again for the Haglund's deformity.
Right.
But sometimes if they have the pain there, but also deep where the Achilles attaches, can't do that arthroscopically because you're going to start chewing up the tendon. Doesn't lead for a good result.
Right.
So that's where we go to a more open procedure.
What's that?
Yeah, so it's a mini open, so it's a small incision about 3 centimeters on the back of the heel. There are different ways to do it. Sometimes you split the Achilles tendon and you find that bump, take down the calcification with a burr or saw. We take that down and then reattach the Achilles tendon. Sometimes for bigger, spurring and big bony promises that are built up, we do detach the whole Achilles tendon.
Right.
We saw off the spurring in the back of the heel and also that kind of bump, make it nice and rounded, and then take off the inflammation from the Achilles tendon to debride that, and then reattach the Achilles tendon with some bioabsorbable anchors.
And this actually, for all you basketball fans, is what Larry Bird had in the late 80s.
A little different. I'm sure they did a bigger incision
Much,
then.
for sure.
So again, we always try to minimize the incisions in the back of the heel. And then, they're in a cast usually for 2 weeks, non-weight bearing, and then we get them in our post-op protocol where they could walk at 2 weeks with an air boot and heel lifts that we just every couple weeks.
I didn't know Larry Bird wore a lot of pumps in the day.
Yeah, I think he wore bad Converse shoes. Who's kidding who? Look at the shoes those guys wore in the 80s. Jordan blew out his first
jump
pair.
shot, probably.
Yeah, exactly.
Okay, so and these surgical treatments, do they have a good success rate? Is it hit and miss?
Yeah, so once we go, again, like I said, if we go through that non-operative route and it doesn't work, I think that's where it leads to surgery, and patients are quite happy. The one thing I would say is do not ever get a cortisone injection in the back of the heel for your Achilles.
Okay, so great question, because people always ask us this for wherever we inject anywhere. Why does it matter getting an injection into your Achilles tendon or the insertion down there?
Because it could cause a rupture.
Right.
And I've seen that happen. Patients come back and say, Doc, I got that floppy foot. And I ask what happened, and they say, well, the doctor did an injection, and now it's
It's a big problem.
It's a huge problem.
Like always, whenever you consider a surgical intervention, there's risks and complications that can happen. What are some of the risks and complications that can happen with these surgical interventions?
Yeah, so again, if we're doing it arthroscopically, so small risk of infection, inflammation, nerve injury, tendon injury, vessel injury, small risk of blood clots after the surgery, chronic pain, like any foot procedure or ankle procedure. If we're talking about doing that open procedure, higher risk of wound complications, although still quite small. Risk of detaching the Achilles tendon, so it could technically lead to a rupture, nerve injury, vessel injury, and whatnot.
Okay, so although bad things can happen, the risk of something bad happening is very, very, very small, and your surgeon will take precautions to minimize the chance of something bad happening. But you should be aware that these risks exist before you decide to proceed with one of these elective procedures.
And I think it's important to recognize that these are often chronic problems, so they're not going to be solved quickly. So what would you say is your standard approach for non-operative treatment? How long of a go do you give at it?
So usually it would probably say about 2 to 3 months,
Right.
give or take. And a lot of times you want to try a couple different things, maybe hit it hard a couple things for a multimodal approach. If that's successful, then that could be the best way.
You're
to
not
go.
rushing into anything.
No.
Yeah. And if you've had the surgery and it's very successful, don't say, oh, I should have had this done a long time ago. You shouldn't have. You have to try the non-operative stuff first, because the chance of getting better with the non-operative stuff is very, very, very high. Even though you couldn't get better with the non-operative stuff, it's unfortunate, you had surgery and then you got better. There's probably 9 other people who had non-operative treatments that did get better. That's why you didn't have the surgery right away.
The other thing I would say too is a lot of the near replacement satisfaction literature shows that the longer you've suffered, the greater your relative improvement is, so the happier that you are. So as much as we're not sadists, we don't want you to suffer for a long period of time, but it actually makes you value your improvement greater.
Yeah, we could always do a surgery, just can't undo it.
That's
There you
right.
go.
I like that.
Well, that's a good summary of heel pain at the back of the heel.
So if you like this video, please like it, subscribe to our channel, and share your comments about Achilles tendonitis.